Thanks for joining us. My name is Matt Point, and I am the Director of Advancement here at Children with Diabetes. I wanted to give you a few announcements, and then I'll introduce our guest speaker for the evening. So first, I want to let you know that this session tonight is recorded, and then it'll be on the CWD website at cwd.is/screenside in a couple of days. So if you, when you want to rehear what you've heard tonight, or you have a question, you're like, oh, what was that thing? You can check it out again online later this week. That said, we are going to be taking questions during and at the end of the session. So if you do have a question, feel free to pop it in the chat box. You can send it directly to me. You can send it to everyone. And if you also have a question that you would like to potentially ask anonymously, you can use the Q&A feature to ask us directly, or ask anonymously through the Q&A feature. I can't guarantee that we'll get through all of our questions tonight, but if you have something, please ask it. And then the last thing is, we want to say just thank you for being here tonight. Next, I want to introduce our speaker, Dr. Henry Anhalt from Provention Bio, who is here to speak with us this evening. Thanks, Henry, for being here.
It's a pleasure, Matt, and thank you so much for the invitation.
Anytime.
So good evening, everybody. I appreciate very much your spending this hour with me here doing a screenside chat. Before I get started, I just wanted to say for disclosure that I am an employee of Provention Bio, and I'm going to be speaking with you tonight. But I don't want it to be a lecture. I want it to be a dialogue, a chat, if you will. So please interrupt. I know there's a raise hand function. Please use it. I think it'll make for a more exciting and interesting interaction. So we're living in extremely exciting times in type 1 diabetes. And I'm reminded of the fact that most recently we had the 100th anniversary of the discovery of insulin. And I think about all the advances, or the lack of advances, that we've had over these 100 years. And it struck me that we're living now in a time of many things that are possible, a world of many possibilities. So I recall that when I spoke to patients about 15 or maybe even more, 20 years ago, I told them, don't worry, a cure is coming and it'll probably be there in 10 years or so. Of course, I now have to look at those same patients in the eye and say, we didn't deliver. But now we are, I believe, at the threshold of a new beginning, and perhaps even a shorter runway than the 10 years. So let's go to the next slide, please. So we're going to be talking about T1D screening, what it is, how it works, and why it's important. It's not going to be listed in any specific order, but these are the themes that will be woven through the conversation. I know this is a little bit difficult to do, but I'm used to doing it when I share and have the opportunity to have conversations with people. I like to get a sense of who it is that I'm speaking with. So we're going to give this a try and we'll see how it goes. But how many of you in the audience are people living with type 1 diabetes? I think you can raise your hand, or I believe there's another way, Matt, if you can, to get that information back.
Yes, so you can raise your hand. You can pop it in the chat for us.
Okay.
So two people with their hands currently raised. Get a note here.
All right, we'll keep going, and hopefully we'll get that information as time goes on. Type 1 diabetes screening has been available for a long time, and it's been available for relatives of individuals with type 1 diabetes through TrialNet, as many of you know, as well as a number of other research-based screening and clinical trial programs. Some of the screening programs are focused specifically at relatives, or what we would say people who are at greater risk. And some of the screening is focused on the population. So obtaining samples across the board in individuals who are born in a certain geography or for other criteria, but a much broader look at the risk of developing type 1 diabetes by screening. So up until now, the general public really had to go through a little bit of a challenge in getting that screening done. They'd either have to go through TrialNet if they were lucky enough to be around a TrialNet center, or they received their care at a center that was doing that kind of clinical research, or for that matter, that their physician had to order it. But we're living in a time now where people living with disease and their families can empower themselves. And so the JDRF started a program called T1 Detect. It requires no prescription. It requires no physician to intervene, and it requires no commitment to participate in clinical research. Now, the way that works is you can go on the JDRF website. There's a link to the program T1 Detect, and you can order your kit. And you don't have to have any criteria to be met in order to order the kit. There's a cost to it, and it's subsidized if need be, but you can empower yourself and decide who it is that you want to share that data with once the results come back. Let's go to the next slide, please. So this is going to give a little bit of background, much of it familiar to the people on the call. And in fact, I always feel that I learn more from the folks that I'm speaking with than it is that I come to you with my own knowledge. So it wasn't that long ago that we finally realized that type 1 diabetes is an autoimmune disease. No one really knew what caused it. And in fact, again, I think back, I was giving a talk on Sunday to a support group, and a father reminded me that I had diagnosed his daughter 20 years ago. And I had told him at that time that the likelihood of his other child developing type 1 diabetes was almost infinitesimally small, and that in fact he should take all of his money and go to Atlantic City and bet all of it that in fact his second child wouldn't develop. Well, of course, that second child ended up developing type 1 diabetes, but at that time we were really starting to just get our hands into a better understanding of type 1 diabetes as an autoimmune disease and some of the risk factors for type 1 diabetes. So family history, again, that was something we didn't think about. Family history, most people said, you know what, I don't know anybody in my family. And that's true. For the vast majority of people who develop type 1 diabetes, they don't have a family history, but about 5 to 8% actually do. And those individuals who have a family member with type 1 diabetes have a 15-fold greater risk of developing type 1 diabetes themselves than the background population. Furthermore, we know that there are certain viral infections that are called enteroviruses or a Coxsackie virus, and many of us have heard of Coxsackie. Provention Bio is working on a vaccine for Coxsackie virus, but there are things in the environment that are not well understood, although significant progress has been made in trying to identify them. We don't really know. I'm sure some of you know people who live in the same area who developed type 1 diabetes within a 4 or 5 block radius or certain pockets. We know, for example, that as we go from the southern hemisphere and we move upward through the northern hemisphere, the incidence of type 1 diabetes goes up. And so one of the areas of focus has been vitamin D. Is it vitamin D that potentially could be deficient in those individuals? And that perhaps present the greatest factor in that population. And we also know that Sardinia, which is an anomaly, but it's sitting in the middle of the sea, also has one of the highest incidences of type 1 diabetes. We've also learned that there are about 60 different genetic profiles that we can identify by looking at someone's genes that put them at either greater or lesser risk of developing type 1 diabetes. And you may have heard something called HLA, and HLA, basically, I like to think about it as a protein packet that's sitting on the top of a white blood cell. And certain ones put you at greater risk and certain ones don't. And then there are immune system components. So we're teasing all of this apart, but there clearly are, from what we have now learned, a greater understanding of how much family history can play a role. In the general population, developing type 1 diabetes by age 20 is about 0.3%. Having a first-degree relative with type 1 diabetes increases the risk approximately 15-fold, as we said, resulting in approximately 5% risk. That's a significant difference. Similarly, the lifetime risk of developing type 1 diabetes among the general population, lifetime risk, is estimated about 1%, whereas the risk among individuals with a first-degree relative can be as high as 10 to 20%, depending on if it's a father or a mother. And lastly, type 1 diabetes is typically only diagnosed after symptoms appear. And unfortunately, so often type 1 diabetes is misdiagnosed. Children and families go to one physician who doesn't recognize the symptoms, and then to another physician because people are not thinking about type 1 diabetes. It's not top of mind. And so diabetic ketoacidosis, or DKA, occurs in about 50% of individuals who present with type 1 diabetes at diagnosis. That's quite a lot. And for those of you who've gone through it, it was, I'm sure, an experience that was disturbing. And if you were admitted to the ICU setting, that too can be incredibly, incredibly painful and difficult. But we know type 1 diabetes doesn't start there. We now know through screening and through a deeper understanding of the autoimmune part of type 1 diabetes that this starts way before. Let's talk about staging of type 1 diabetes now. Next slide, please. So think about this on the left side of the slide and on the right side of the slide. Think about stage 1 and stage 2 as being parts of type 1 diabetes that would not be known to anyone. And stage 3 is what we all have become used to calling type 1 diabetes, stage 3. But let's go to the left-hand side of the slide. So pre-insulin dependent type 1 diabetes, stage 1 is if you have 2 or more antibodies that you can detect in the blood that are they're indicators of damage and autoimmune attack of the pancreas. That starts the diagnosis of type 1 diabetes. And if we think about that, that changes the entire way we have come to understand. But why is it important? It's important because there are therapies and interventions that are now being looked at that can target or can potentially interfere at specific stages along the journey as someone goes from risk or from predisposed at stage 1, ultimately to stage 3 on the right side, where a life of insulin dependence occurs. So stage 1, you have 2 or more of these antibodies, but a normal blood sugar and nobody would know. And this can occur years or months prior to stage 3. Stage 2, 2 or more autoantibodies are present, and the blood sugar starts to get a little bit abnormal. But again, no one would know. Probably the folks who are most likely to know are parents of kids who have type 1, and they already have a heightened sense. But even in those cases where there's a sibling, sometimes either denial or it's in the summertime, we can see parents not necessarily detecting that these are signs of type 1 diabetes that is now becoming more recognizable. And stage 3, the body is no longer able to make enough insulin. And that's when we see the symptoms of drinking a lot and eating a lot and losing weight and peeing a lot. And then, of course, as I mentioned, diabetic ketoacidosis. Let's go to the next slide, please. So testing for type 1 diabetes or screening. The type 1 test, as we'll call it, or obtaining those antibodies associated and ones that can indicate destruction or ongoing destruction of the insulin-producing cells in the pancreas, you can detect type 1 diabetes, as we just saw, way before the symptoms occur. And as I mentioned, it's a type of blood test that looks for these autoimmune markers of destruction of the beta cell. Now let's talk about what happens and how do we interpret these tests. So if you do the test and you have one of these antibodies, you're more likely to develop insulin-dependent stage 3, or that final stage, than someone with no antibodies. However, if the test finds 2 or more, you have type 1 diabetes, but are in the very early stages. So the risk of developing type 1 diabetes is approximately 25% within 3 years, approximately 70% within 10 years, and up to 100% in the lifetime. So it's important to note that even in the absence of requiring any insulin, and even in the absence of having blood sugars that would create symptoms, you have type 1 diabetes, the beta cells are being attacked, and that it's extremely likely, overwhelmingly likely, that you will develop stage 3 or insulin dependence in your lifetime. Next slide, please. So why do I get tested? And that's a question that I'm sure many of you have had, many of you have struggled with. And we as healthcare providers and partners in your care have had to face those questions and not necessarily have answers that made a lot of sense. What do you do with this information? Is it better to know, or is it better not to know? I wish I could ask you, and I'm going to anyway, how many of you would rather know than not know? And forget about any other information that you may have. How many of you would rather know than not know? And think about that within the context of type 1 diabetes, or for that matter, any disease. Okay, so why should we test? And Matt, I don't know if you have any numbers to share back on, but let's talk about the potential benefits. So first of all, if we know that someone is likely to develop clinical stage or insulin requiring type 1 diabetes, we can counsel, we can have a conversation, we can establish a relationship and find out what kind of resources we can put towards this ultimate diagnosis. And maybe even as time moves on, we'll see other potential interventions coming up, other clinical trials that people can participate in. This is going to be most certainly true in the near term, as there are drugs that are in front of the FDA seeking approval, if the FDA deems them to be approvable. And there are others that are about to be submitted to the FDA for approval. So there is now a real potential to have interventions that may make a difference. And given that interest, we are seeing, I dare say, dozens of companies who are actually jumping in and saying, now that we have the potential to understand more about genetic risk, we can, or risk in general, we can start seeing a reason to support screening, and that potentially there are interventions that make sense as we tease apart what the autoimmune piece is and how genetics play a role. So people can know what to expect in terms of symptoms. And why is that important? I mentioned just a couple minutes ago that 50% or so individuals have DKA when they present. So knowing the signs and symptoms and being prepared and having that education in place can hopefully avoid and decrease the risk of having DKA. And we know that that's the case. There are studies that have been done across the world, both in those individuals who are at greater risk because of a relative that may have it, but also in population screening. And that makes sense because if you are attuned and you're aware, especially when you know that there is a lifetime risk that nears 100%. In one trial I'd like to call out, only 3.3% of children who were identified as genetically high risk and who were followed closely were hospitalized at diagnosis, compared to 44% of the general type 1 diabetes population. So this is an important factor to remember. Putting your healthcare team in place, being able, if needed, to have those fears and the psychological worry be addressed, because there is that sense of when is the shoe going to drop, understandably so. But
we actually have a question from the audience. I think it's really applicable, so I wanted to grab your attention on it.
Excellent.
My 2.5-year-old had his A1C tested in January after his sister was diagnosed with T1D. It was 5.0. I had him retested at his physical last week and it was 5.5. Should I be worried? He is almost pre-diabetic. He just became old enough for TrialNet and we are waiting for the results. His pediatrician was not sure how to interpret the data.
So thank you so much for that question. And I hope that your second child, that things work out for the best, and that he or she is not going on to develop clinical and insulin-dependent diabetes. What I would say is the results from TrialNet will be important because they will help understand whether or not those antibodies that are associated and are indicative of destruction of the beta cells and a decreased function of the beta cells, if they're there. And so if they're there, the conversation needs to be about what to do next. And my recommendation would be always to speak to a healthcare provider who could guide you about what the next steps are. What additional testing, if any, needs to be done? What additional screening should be done, if any, should be done? So I wish I could tell you, don't worry, everything is fine. But I would say, let's wait and see what the results. A1C by itself is not the best indicator of whether or not somebody is at risk. And so I would say, as best as you can, hold tight until you get the results. And then I think the next step would be to ensure you engage in a conversation with someone or a team that knows how to interpret these results and help you go to the next stage.
Thank you. And just so you know, I just dropped some a few of the materials from the Type 1 tested program in the chat. So if you are interested, I would definitely check those out if you're in a situation where you're waiting on TrialNet results, because they could definitely walk you through some next steps of what you could do to prepare and based on the results of what you receive.
Let me pause for a moment, Matt, and see if there are other questions that people would like to ask before I move through the rest of this particular slide.
how would do you have any recommendations for dealing with family members who are struggling with the decision on getting testing because they're concerned about the results, whether it might be guilt as a parent having type 1, or concern that it might be their fault, or that they feel that way, that that they did this to their family? Do you have any recommendations for how to have those discussions or to work through them?
Yeah, that too it's a difficult question to answer. People have many different reactions to finding out that information. In another family that I care for until today, the father has type 1 diabetes. And many years ago, I diagnosed one of his children with type 1. And 3 weeks later, the second child developed insulin requiring type 1 diabetes. It's the elephant in the room. The dad is an educated person who knows. The kids, one is a nurse, the other is a graduate student in political science. They, as a conversation, have had that conversation in their family. I can't imagine how the dad feels. On the other hand, and not to dismiss that as being a serious issue, we take the good stuff that we get from our parents, right? It's not all, okay, you put me at risk. I'm sorry, my dog is barking. So, you may put them at risk, and that's true for many disease states, whether it's breast cancer or other conditions that are inherited. Yes, we do feel guilty, many people do. But on the other hand, there is to some degree an appreciation of what that means for a family unit. So I don't think it's a straightforward question to answer, but I'm humbled by it because it must be a very, very difficult one. I would say the other piece of this is not to try to force the issue. I would say people have the information, they can think about it, they can consult, but it shouldn't be something that has to be decided on the spot, that the screening should take place as people work through their conflict, their worries, and legitimate concerns about having this information and what it means.
Thank you.
Any others? Okay. I want to mention one other piece of information around DKA. And this, to me, is a very, very compelling reason to avoid experiencing DKA, not only in the immediate time of the diagnosis, but we know that if we can avoid DKA in general, and certainly at diagnosis, the risk of long-term complications are lessened. The cells, the beta cells that make insulin, are not suffering the same kinds of destruction or loss of function when DKA does not occur. And so if you look out years, the glycemic levels in people who've experienced DKA can oftentimes, the data has shown, be not in the same range as people who did not. And we don't know exactly why that is, but an important piece of information. It's not only for the here and now and the risk, but rather as we look at risk on a longer term trajectory of years later. Any other questions about this before I move on? All right, so let's move on to the next slide, which is the ways to get tested. Now, remember early on, I had talked about being empowered. And I think that, when I think about being empowered, I think about the question that I often ask patients when they come to see me. I say, so why are you here today? What can I do for you? And what are your expectations? How can I help? And some people living with type 1 look at me and they don't know how to answer that, because the question of how we co-develop a treatment plan is something that many people are still struggling. I don't want to bother the doctor. I don't want to ask any questions. And I think you need to be empowered and you need to advocate for yourself. The doctor-patient relationship has to be one of mutual development of plans that work for you as people living with type 1, as well as your relatives and your family unit. So you should go into a physician or a healthcare team visit with the expectation that you will be provided tools and knowledge that you need, but it may not happen unless you ask for it. So before you go to a visit, write down your questions, have them in mind, and don't be afraid to ask. So how do you get tested? Well, you can go to a doctor's office and the doctor can take out one of those slips or go into the computer and order it directly from the lab. And you go to the lab in the hospital or in the clinic and they draw your blood and off it goes and the results come back to the doctor. Through an at-home kit, as I mentioned, the T1 Detect program, which you can find the link on the JDRF website, you can get one of those kits. No one has to order it for you. You can order it yourself. You can decide who you want to give those results to. And there is a doctor available to you who could help you understand what those results say, should you choose to want to get that kind of input. And ultimately, it's a decision that you should make either with conversation with your healthcare team or not, depending on how you feel about it. However, keep in mind the parts of the conversation that we had earlier about what having those antibodies present in the blood indicate and whether it's best for you to have a conversation with people who can provide guidance. And lastly, if you're given a slip by your healthcare team, going to a laboratory like a Quest or a LabCorp or others, and having the blood drawn there. So those are the primary ways that today people can get tested or screened for their risk for type 1 diabetes. Any questions about that? Great. Matt?
One question. If someone were to test and they got a result that they didn't have any antibodies, but they have a family history, do you suggest retesting? And if so, how often?
You know, sometimes when I give a talk and a question comes up and I say, that was a really great question, I say to myself, am I saying that after every question? But each one of these questions have been really important and great questions. The answer is, I can't tell you because I don't know. There are studies that are looking at the natural history. There are studies that have said, you know, if you have family relatives with type 1 and you have no antibodies, depending on the age that you had that screening done, you should consider having it done again at age 5 or at age 11 or whatever the paradigm will be. It should be a conversation that takes place with your healthcare team, because at the end of the day, we don't really know what is the best approach. And certainly I would be stepping out of bounds if I was to say, this is what you should do. I do think it's a reasonable thing to think about having another test done, given what we've already spoken about risk, but how frequently, what other monitoring should be done, at what age, that's a conversation that I think is best held with your healthcare team.
Thank you.
All right. let's go to the next slide, please. So what do these results mean? And then what are the next steps? Because this is a follow-on question that it's a question I'm asking all of us to think through. What do you do with this information? So some guidance that has been put together by what we call an expert consensus, and it's available on the JDRF website, but it's not the standard yet of care, not because it's not good enough, but because it's at the point where it is a group of incredibly brilliant people who have worked in this area for so long, who have the most experience. They have put together these guidelines of what they think should happen. And it's being discussed. But again, it's up to the healthcare provider and your conversation to make a decision of what the best approach should be. But let's go through them. So if you have 2 or more antibodies, you're likely in the early stages of clinical or insulin requiring, on the journey to insulin requiring type 1 diabetes. So what can you do? What kind of steps can you do, even without any guidance of further evaluations or testing? Well, you can learn the symptoms and you can watch out for the symptoms of clinical or symptomatic insulin requiring type 1 diabetes. You can monitor blood sugars. How that's done, when that's done, is not entirely solidified from recommendations. There are people who are looking into different kinds of approaches, including potentially using a continuous glucose monitor at times. But again, there is no guideline yet approved, but it's something that so many of us are trying to drive towards to ensure that the momentum of screening continues and the awareness continues, not only for all the reasons we've already discussed, but also to accelerate recruitment for clinical research and to be prepared when, and I believe when, those treatments come to market. Build your healthcare team. Have a dialogue. You know, moms, when they're pregnant, they go and interview pediatricians. They want to know what that relationship is going to be like. Stay ahead of the learning curve. Keep in mind and think about the things that you can learn rather than a crash course that happens when you are stressed and it's much more difficult to focus. And I ask you to think back, if you can, to when the diagnosis was first made and how many things were swirling around in your mind and how much did you retain and how much didn't you retain. And you know, it's hard for me again to imagine what that's like, but I can only imagine how challenging that is. If we go to the middle bubble, one autoantibody, yes, you have a higher risk of developing insulin-dependent type 1 diabetes than someone with no antibodies. But what do you do? And this is a little bit back to the question that the other person asked. Talk to your doctor and determine when and how often to get screened, to look for other autoantibodies or other indicators of ongoing. Because if you have one, does it mean you're going to develop a second? Absolutely not. But you may, and especially in the setting of having a relative with type 1 diabetes. And lastly, the bubble on the right, no autoantibodies. Here it's recommended you continue getting tested every year if there's a family history. So a moment ago, we talked again about what to do if there are no antibodies. Do you get tested every year? this is one example of an idea of getting tested once a year if there's a family history, but some people may prefer to do every 6 months. Some people may prefer to do it at 2-year intervals, etc. Talk to your doctor and talk to your healthcare team. However, if you have 2 or more autoantibodies, speak to your healthcare team, professionals who know what these tests mean and what the next steps should be. Let's go to the next slide.
Can you
yes.
What is the name of the autoantibody test that's actually being done? What type of test is it, or does it have like a specific name to it?
Yeah, so there are a number of antibody tests that are done. The test itself, there are names of the assays that I think are perhaps a bit technical, but there are antibodies that folks may have heard of, GAD antibody, they may have heard IA2 or ICA. These are antibodies that are often the most commonly measured, but they are present in different people at different stages. TrialNet may measure some. This test from the T1 Detect may measure others. So there are a number. Some are done in commercial laboratories and some are not. So it really depends on where it is that you're having the testing done. And I would say that the specific names of the assays themselves are quite technical, but I hope that answers the question.
I think it was more in terms of if we were going to go ask our doctor for something, what should we call it if we were?
Yeah, so I think the best thing to do is to tell the doctor, look, I want to be screened for type 1 diabetes. I want you to check to see if I have antibodies in my blood that are telling me something that I may be at risk. Now, what may be true is that some of the doctors that you speak to may not know about screening. They may not know that there could be a greater risk of a relative having type 1 diabetes if they are a relative of someone with type 1 diabetes. And here's where the advocacy, self-advocacy, and the need to be your own advocate in healthcare. There's nothing wrong with educating your team. There's nothing wrong with educating the doctor and saying, look, I heard about this. I know that I can get this screening done. Will you help me get that done? I want to have the antibody screening for type 1 diabetes. And it's not a big deal on the laboratory slips. It's right there. It's not an unusual or a difficult test to obtain. The doctor doesn't have to do anything specific. It's just like they would order a blood count or a sodium level. It's the same thing. It's a tick the box. And certainly if you do it through the T1 Detect program, that is specifically meant to measure those antibodies. And in that case, you don't need to necessarily, or you don't need to ask anything about any particular antibody. It all gets done through that test.
Thank you. We got to know, you answered the question.
All right, so next slide. So I believe we're living in a really, really cool time right now that you can take your phone and hold it to the code and you will get signed up for Together Through Type 1. We have a community on Facebook and Instagram at Type 1 Tested, as well as on the web, www.type1tested.com. And Matt, I think you had put into the chat some of the other resources that we wanted to provide to people who have joined.
Yes, I'm going to re-drop all of them into the chat.
And at this time, it's 13 minutes before the hour. My presentation is finished. And Matt, if you just want to go, oh wait, you know what? Let's leave this up because people may want a little bit more time to jot this information down. But now would be a good time if people have questions, or let's engage in a dialogue over the next few minutes.
So I dropped all of the links into the chat. So I would copy and paste them into a Word document or to a note in your phone, wherever you're watching, so that you have them. But if you have any questions, feel free to pop them into the chat now, or you can ask through the Q&A box as well. Whatever's easiest for you. What do you think are one of the most important resources for if a parent were to get the results back and their child was to test and they have 2 autoantibodies, what do you think is the first real step beyond, just getting in touch with their team? What is it? Setting up potentially a mental health type of appointment, or what would you think is the next the next best thing to do for your kid? What would you do?
Yeah, so I think that it has to be an individualized approach, because for some people, they want to go action. They want to know what's the next step in terms of an intervention. I don't want this to progress. For some people, it could be a devastating piece of information. For some people, it will be getting to a healthcare team for further discussion and next steps. I'm always in favor of folks getting educated and arming themselves with information that's out there and learning. But for many people, there's not going to be a one size fits all. It's going to be individually based on need that people have. And I really do hope that people can have that level of comfort that they could go back to their healthcare team and get guidance from them, from their family members, from the community. CWD is an amazing, magical community. And, I've had the pleasure of being associated with CWD for many years. And I know that there is support that CWD offers, and maybe connecting with Matt and the good folks at CWD could also be a good place to be. But one should be prepared for all kinds of feelings that to contend with and that they may want assistance with. And I think that that's something that should be recognized. So that's what I would advise as an outsider looking in.
Thank you. So we have a few questions popped up. I'm going to throw them at you. So first, I'm assuming this one is in regards to the COVID vaccine. Is the MMR vaccine a known risk factor for developing type 1 diabetes?
I would love to answer that question, but I don't know the answer, and it's beyond my area of expertise. So I wish I could answer it, but I don't know the answer.
Next one. Does the T1D screening test take extra time to complete at the lab? We're waiting for TrialNet, 4 to 6 weeks, but I could request from a pediatrician at a regular lab and find out more quickly. I didn't realize I was able to ask at the doctor's office.
The answer is yes. It would be a lot quicker than 4 to 6 weeks. And certainly if you were to order it from the T1 Detect program, I believe the turnaround time is about 2 to 3 weeks as well. So the quickest way may be through the doctor's office, but very important, this piece, please pay attention to, that it sometimes can be a quick, not mindful checking off a box on a lab request that gives you one test versus the whole panel of tests. So if you're going to have your doctor do it, make sure to ask for the whole panel, ask for the whole kit and caboodle, because otherwise there may be just one test, and sometimes it's called GAD, the GAD test that the doc may order, but there's usually an antibody panel, and that's what you should ask to be done. And it's no more difficult as just checking another box or putting the code on the form. And all those codes you can look up. There's no challenge for the healthcare team to do that. So you have a number of different ways of approaching it.
Thank you. And we just got to thank you for answering the questions. And are there any other questions out there? You can shoot them in the chat. You can put them in the Q&A box if you want to ask anonymously to just me. But we're happy to answer anything that you have. I think we already answered that one. Okay. I think that's it for now. Does anybody any last thoughts you want to share? Or?
Yeah, I'm so grateful that you've spent your time, your precious time with me in the summer and on a Sunday evening. I feel privileged to have had the opportunity to speak to you about this. Again, I want to reiterate that exciting times in type 1 diabetes. Be empowered, ask the questions, get screened, because I think that the next few years are an exciting time. And it's not only the medical and the psychological pieces to this puzzle, but rather the good that can come out, whether or not it's something around clinical research or whether or not it's something that you want to think about as interventions that come along, or just to be prepared. So have a great rest of your weekend and a great week. And I look forward to chatting with you again.
Thank you. And we had two more questions pop in while you were chatting. I think they're really important. So I do want to grab them real quick, if that's okay. First one, can you get fast tracked onto trials with a positive autoantibody test?
So antibody testing is oftentimes a requirement for clinical trials. And depending on what are called inclusion or exclusion criteria, the inclusion criteria may require having antibodies present, but it really depends on the clinical trial. So for example, Provention Bio has a clinical trial that's ongoing now with the drug teplizumab in individuals with new onset clinical or symptomatic or insulin requiring type 1 diabetes that have to be enrolled and receive either the drug or the placebo within 42 days. And part of the qualification is having antibodies. And so that's an important piece of information to know. But it's just an issue of whether or not there is a clinical trial that's right for you and whether they require having the antibody test as part of the enrollment criteria. If they do, typically it'll be a test that's drawn as part of the qualification for participation, and it'll be sent to a laboratory, usually a laboratory that is analyzing all of the samples to ensure that those antibodies are present.
Got it. Thank you. And the last one that popped in was in regards to misdiagnosis. And there was a percentage of type 2s that are really that are really misdiagnosed type 1 or vice versa? Is there any effort to get more type 2 screened for antibodies?
Type 2 diabetes screening with antibodies is an interesting question, because we know that there are some individuals who have developed insulin requiring type 1 diabetes in their 50s and 60s, and they may be very overweight. And sometimes it's part of the diagnostic evaluation where antibodies would be useful to sort through whether or not the person has insulin requiring type 1 or they are genuinely type 2. It's a little bit more complicated when you start to get sort of this mixed picture, but suffice it to say that a typical situation would be somebody who an internist sees, the person's 50, 60, and they develop hyperglycemia, high blood sugars, and their hemoglobin A1C is out of target. And they'll put them on metformin or some other drug for people with type 2 diabetes, and they don't get better. And so if somebody has a child with insulin requiring type 1, it doesn't mean that it can't go back a generation, if that makes sense. In other words, I had a kid who I diagnosed, and he said, yeah, my father has type 2, and the dad was 65, and he was on metformin, and he was on a bunch of other drugs, and no one measured his antibodies. And despite his age, where it may be that somebody who's had type 1 diabetes for many years, their antibodies may not necessarily be there. It's sort of the pancreas burns out, and so there's no more of those antibodies that are indicating ongoing destruction of the cells. His antibodies were strongly positive. So he had insulin requiring type 1 that was misdiagnosed and being treated as somebody with type 2.
Got it. Thank you. And last one that popped in while you were speaking is the Provention Bio trial age dependent, the one that you have to begin within 42 days.
Yeah, it's 8 to 17 years.
8 to 17. Okay, thank you. Well, I think that's it for our questions tonight. I want to thank you again for being here. I want to thank our friends at Provention Bio for allowing you to be here tonight. I really appreciate it. I think this was really important information that a lot of families really need to hear, and I'm glad. Thank you, everyone in the audience, for joining us tonight and popping in on a Sunday night. But if you have any questions, I welcome you to reach out to us at Children with Diabetes. Check out our website, or if you're interested in any of our future Screenside chats, you can check them out at cwd.is/Screenside. So thank you again for joining us, Henry. We really appreciate it. So, and everyone have a great evening.
Yeah, you too. Have a good night.
You too. Bye-bye.
Bye now.